Physical exam findings in a patient with chronic mitral valve insufficiency, that is, chronic MR. Hello, I'm Dr. Habibi, and in this video, I intend to explain the Sufis of the heart in simple and understandable language. So stay with me. For a systematic approach to physical exam findings, we use the word script, as stands for sight, which is where we hear the murmur of chronic MR the loudest. It's at the apex area, or the mitral area, and in the left lateral decubitus position, that is, when the patient is lying on their left side, the intensity will be greater. C represents character. A murmur caused by MR has a blowing quality, meaning it sounds like a whooshing. The letter R stands for radiation. The murmur from chronic MR radiates to the axilla and the left sternal border. The letter I stands for intensity. The murmur from chronic MR is variable and depends on different factors. But usually, the intensity of this murmur is moderate to high. The letter P stands for pitch. The murmur from chronic MR is high-pitched or high frequency. The letter T stands for timing. The murmur from chronic MR is holosystolic or pansystolic. That means it is heard throughout the entire systole, from S1 to S2. Now let's move on to other physical exam findings besides the characteristics of the murmur itself. The first part is the features of chronic MR on heart sounds. In a patient with chronic MR, an S3 gallop is heard on physical exam. The S3 sound is heard at the beginning of diastole, immediately after S2. What is the reason for hearing the S3 gallop? As you know, during diastole, the left ventricle fills in two phases: early diastole and late diastole. Early diastole happens at the beginning of diastole and is caused by the accumulation of blood in the left atrium, which, immediately after the mitral valve opens, rushes into the left ventricle. Late diastole is due to the contraction of the left atrium, which pumps the remaining blood into the left ventricle. Now, why is a gallop sound heard in a patient with chronic MR? A gallop sound is heard when either the left ventricle has become dysfunctional or the volume of blood entering the left ventricle from the left atrium has increased. In a patient with chronic MR, during systole, a large volume of blood flows from the left ventricle into the left atrium. This regurgitated blood, along with the blood returning from the lungs, enters the left atrium, and then immediately after the mitral valve opens during diastole, all of this blood flows from the left atrium into the left ventricle, leading to the gallop sound being heard. The next characteristic in hard sounds is a soft S1. In a patient with chronic MR, the first heart sound is heard as very soft and weak. The next characteristic is wide splitting of S2. In a patient with chronic MR, we first hear the A2 sound, and then, after a delay, the P2 sound. As you know, during inhalation or inspiration, venous return increases, and this causes the time it takes for the right ventricle to empty to increase as well. That's why the sound of the pulmonic valve closing is heard later, and with a delay compared to the sound of the aortic valve closing. In a patient with chronic MR, during the time when the ventricle contracts, in addition to the blood that exits the aortic valve, a large amount of blood also regurgitates into the left atrium, which causes the output of the left ventricle to be twofold, both toward the left atrium and toward the aorta. This leads to the left ventricle being emptied of blood sooner, which causes the aortic valve to close sooner. This means that the A2 sound is heard earlier. That's why, in a patient with chronic mitral regurgitation, A2 becomes separated from P2 both during inspiration and expiration, which is called wide splitting of S2. If you found this part of the video helpful so far, please like it and share it with your friends. And if you don't want to miss my future videos, please subscribe. The next characteristic is a loud P2, because in patients with chronic mitral regurgitation, they develop pulmonary hypertension, and this pH causes the P2 sound to become louder. Another feature in patients with chronic mitral regurgitation is the development of functional mitral stenosis. In a patient with chronic mitral regurgitation, when the left ventricle contracts, a large amount of blood flows into the left atrium, and then during diastole, that same amount of blood has to flow back again, causing overflow across the mitral valve. This overflow leads to the development of functional mitral stenosis, meaning it results in a mid-diastolic murmur. And if this happens in acute rheumatic fever, we call it Carey Coombs murmur. So, Carey Coombs murmur is a functional mitral stenosis caused by overflow across a normal mitral valve in a patient with acute rheumatic fever. The next characteristic is the changes in the intensity of the mitral regurgitation murmur with cardiac maneuvers. Mitral regurgitation is an afterload-dependent murmur, and any factor that increases afterload will increase the intensity of the Mr. Murmur. Therefore, the Mr. Murmur becomes louder with hand grip, that is, clenching the fists, and with squatting because both maneuvers increase afterload. And factors that decrease afterload, such as standing up or the Valsalva maneuver, lead to a decrease in the Mr. Murmur. What features are seen on inspection and palpation in a patient with chronic MR? Because over time, the left ventricle becomes enlarged and hyperdynamic when we place our hand on the patient's chest. We can feel this increased cardiac activity as an LV lift or LV heave. And in cases where the MR is severe and has been present for a long time, it can lead to pulmonary hypertension. This pulmonary hypertension, in turn, causes right ventricular enlargement and hypertrophy. So in these cases, we can also feel an RV heave and RV lift. And on the other hand, due to enlargement of the heart and the left ventricle, the PMI also increases and shifts to the left and becomes more lateral. The next change is in GBP. In patients with chronic MR for a long period, due to the development of pH, a series of changes occur in the JVP curve. In these patients, the JVP is distended and jugular pressure is increased. And on the other hand, due to the pulmonary hypertension that is developed, these patients also have tricuspid regurgitation. And as you know, tricuspid regurgitation leads to the formation of a CV wave. That means the C wave directly connects to a large V wave like this. So, because of tricuspid regurgitation, a CV wave is produced. In patients with severe chronic MR, in addition to a high and leftward murmur, we also have a thrill, which indicates the severity of the Mr. Murmur.